Hello, my name's Liz. I'm the head nurse of our surgical wards. I'm back with my part 2 of my patient handling PowerPoint. So here we go. This one is more about how we handle our care patients and some tips that we've basically just found work really well here at Langford Vets. So the first thing, so this is more for our inpatients now. So we have a patient in consult and we know that they don't really like being handled. They can get quite protective. So we need to be able to handle these friends safely. So in order to do so, we basically will ask the owners to apply a well-fitted and correctly built buster collar. So the correctly built bit is really important, making sure that we're weaving in and out of the buster collars, depending which one you have. Just obviously, if it's not well fitted and it comes apart, we can then get quite stuck. So built correctly buster collar, a well fitted muzzle, and then also a well fitted harness. So on admit, if we know in advance that we're not going to be able to get an IV in our patient that's coming in, we can organise for the patient to be admitted closer to the time of their procedure. And then we can do an IM sedation. So it basically prevents the patient from being left in their kennel, getting worked up and just becoming more and more anxious and fearful. We could also IM the patient with the owner, which is quite nice for the patient. Some patients really need that support from their owner. If a patient prefers more of a hands-off approach, then, yeah, like I said, we can IM with the owner, and then they could actually wait with their dog until they fall asleep. And then when it's safe to do so, we can then enter the room, place IVs and do everything that we need to do, and then we can trolley that patient to the area that we need to go. Once the patient is asleep, we would just need to monitor that safely. So it's only a sedation, it's not an anaesthetic, therefore they might still be roused by noise. So we just need, and touch, so we just need to be really careful with like SpO2s. We're not going to be fishing into a patient's mouth to get their tongue to place a pulse ox on it, because there is a high risk that you could get bitten. So we're going to monitor that patient sensibly, safely but sensibly. Place the IV, apply a long line, extension line, just so then we don't have to get down to the foot every time we need to administer a medication. And yeah, the harness, the buster collar, and then actually it might be appropriate to pop a muzzle on this patient depending how much of a care they are and how reactive they are. So most bites that I've seen here have happened when a patient's been under sedation. So we're not going to be removing that muzzle until it is either GA'd or we're now starting to recover the patient and it's safe to do so. We're no longer needing to touch around their face and things, administer eye drops and whatnot. And then a top tip, if we do need to get access to their tongue, for example, to do an SpO2, even with a muzzle, you can kind of get a syringe, make it really long, so a 1 ml syringe works quite well, and then like lift the lip out the way with their muzzle on. Or if we are happy that this patient is in a deeper sedation, we could pop the muzzle off, hold like the top of the jaw, lift up, and then use a syringe to get the tongue out. And then you could actually place the muzzle back on and then put an SpO2 reader on if we weren't able to get an SpO2 from anywhere else. But yeah, that's definitely a top tip of using a syringe to gain access to the tongue. So handling the aggressive and fearful patient. So again, you can see this point's very important, having the patient dressed appropriately. So we're not going to want to corner them. So if a patient walks into the ward with the vet and I can see that they're either dressed in this way or they just do look very nervous and I will just ask the vet if they would like me to take the dog. And then I'll just stand in a quiet area of the room, or perhaps even go into one of our procedure rooms with the patient, just so then we're not putting them on a dog hook. Most of our dog hooks, or in the ward that I work in our surgical wards, are actually in corners of the room. So if a nervous patient is popped onto a dog hook, we now may not be able to get that patient off. So yeah, that's why I've just got into the habit of just getting the patient, and then I have control of that patient at all times, basically. So once we've taken handover and we know what we need to do, we basically then just need to organise who's doing what. So we've got a 40 kilo patient. They're very reactive. They don't really care to be touched. So they've got a buster collar on and a muzzle and a harness, and they've got a problem with their forelimb. So realistically, we're going to need quite a few people to help. I say restrain lightly, but we're going to need quite a few people to help restrain this patient. And everyone needs to know their role. So our equipment and staff are key. And then it's just having a bit of a debrief, really. So it would be like, right, I'm going to hold the patient, you're going to help me hold, you can place the IV, and then you can be a head distractor or a passer or something like that. Or you might even need that fourth person. So large dog, 40 kilos, rather than holding the patient, if they've got their buster collar on, I would just have one person standing each side of their buster collar and then holding onto their harness. So then if this patient was to turn around while the third person is placing an IV catheter in their hind limb, for example, or while someone is doing an exam, if they turn, our bodies are going to block that patient from being able to get to the person that's doing like the bad thing. The number one rule with a buster collar is to stay behind it. So the second someone goes in front of the buster collar, that patient now might possibly be able to lunge forward. So that's why we're staying to the side of the buster collar. So we need to be efficient. We need to be quite speedy, but at the same time, we don't want to be forgetful and forgetting tasks. So actually having a to-do list. So say, I don't know, we need X amount of bloods and an IV and a pulse rate, for example. Even just those things, it doesn't seem that much to remember, but if something escalates, then we might easily forget. So I just think having a little to-do list just next to you is a really helpful tip, just so then you can have everything done efficiently, basically. So when the patient, when we're handling the patient, we need to make sure that it's on a short lead. We don't want that patient to be having free rein on a long lead, because you then in theory don't have control of that patient. Nice, soft, calm voice and environment. So we would be going into a procedure room for this, especially like if the ward area is really noisy, even just for a basic check, and nothing, I suppose everything to this patient would be invasive, but even if it wasn't classed as invasive, we would still either not allow anyone into the room while we're doing it, just so we have full control of the environment, or we would go into a separate procedure room. So like I said, we're not going to be approaching this patient head on. We're always going to be staying behind the buster collar. This is why it's quite good to have control of your environment, because if someone walks in, they might not know the patient, and they might not know that actually just how reactive this friend can be. We're going to be avoiding intense eye contact and just have nice soft eyes, and then nice calm soft voices. We need to stay calm. And then what I would just say is, if you have any injuries and you're in charge of holding this 40 kilo patient, then perhaps you're not the person that should be holding. So feel free to tap out and ask somebody else. So perhaps the person who's placing the IV is best to hold, and then you can place the IV or do whatever the procedure is. So yeah, if the patient will tolerate an IV, then we would do that how I've just explained, minimal restraint. We love a hind limb if it's appropriate, because the patient, you can safely do one with less restraint. If we have to do a forelimb IV, then we would probably just IM sedate this patient, unless they have a muzzle on. If they have a muzzle and a buster collar, and they're tolerating it, then we may be able to place a forelimb IV. Obviously, it's all going to be dependent on what's actually wrong with the patient. They might not be able to have sedation, and they might have heart disease or something. But I would probably say that less is more with these friends. So yeah. We at Langford do have an amazing protocol for an IM long line. So you can basically sedate the patient from afar. I will be doing a part 3 of like handling our care patients, and I'll be talking about the IM long line in that video. So caring for the aggressive and fearful patient. So if this patient needs surgery, we ideally don't really want there to be lots of dressings on their surgical sites. And we basically just want to reduce the amount of hands-on nursing that we need to be doing. So eye drops, obviously they're probably not going to be that realistic. It all depends on a degree of how stressed and anxious your patient is. Some patients you might actually be able to do it like from afar if you've got good aim. But other patients, even if you do that, they might try and jump up and bite and things. So actually the stress of the patient for doing that, and then also the risk of staff, we're just going to want unrealistic procedures crossed off the sheet and just not put on there in the first place, really. So bladder scans and pain scores, physio and things, it's anything with that physical contact. Some patients might be cool with having physio. It can feel quite pleasant for them. But another patient, they just might be very reactive to any sort of touch. So we're going to be discontinuing any unrealistic procedures off their hospital record, such as mucous membranes. You might have a new person or a student walk into the room, and because it's there, they feel like they really need to do it. So if it's not there, there's just not that risk of it being done, basically. So we're going to be avoiding touching and restraining close to the painful area where possible. Obviously, it's unnecessary touch and stress to that patient. And yeah, nurse with a hands-off approach where possible to avoid unnecessary contact. So this goes back to kind of being organised as well during a patient check, for example. So actually, rather getting the patient in and out of the kennel multiple times, have your food, have your medications, have everything ready before you then get the patient out. And then you can just do everything in one go. So one thing that I suppose the patients that we see here, they tend, or in surgical wards, they tend to come in and they most likely will need some form of sedation to have imaging. So for us, actually, if they need bloods or I'm not sure, an FNA or something like that, can that procedure be done a little bit later in the day when that patient is under sedation or having a GA, just so it's, again, nicer for the patient. They obviously won't know what's going on, and it's just safer for them and us. So we tend to do our care dogs patient checks last, and that's purely because we can then give them the time that they need for us to complete that check. We don't want to be rushing, like I said, we need to be efficient, but the second everyone starts rushing, that's when errors happen, really. So again, if we are going to be walking a reactive, so perhaps a reactive dog out, so they might be lovely with humans, but just a bit reactive with other patients, we will call round to our other ward areas and just say, we're going to be walking our patient out, please don't walk anyone in the next 10 minutes. Just so then that's as stress-free walk as possible for that inpatient. So when a patient is really quite reactive and we haven't made friends, we haven't made much progress during their stay to become friends, then it's quite sensible to starve them the night before we think they're going to go home. And this is basically so we could administer some form of sedation just to help us remove an IV catheter, for example, or Primapause, and just give them a general spruce up. Obviously, these patients that we see, they may have been in for a few days and they've had this buster collar on, they've got food in it. So it's quite nice if we're able to just clean them up basically in a safe way. So that's definitely a top tip, rather than trying to fight with a patient to get an IV out, which isn't nice for anybody involved. We can just give a little bit of sedation. And then in all of our areas in the hospital, we have Pet Remedy and Adaptil plugins. But with our anxious friends, we will spray in their kennel on like curtains, so on towels, we'll hang up in their kennels. And we do have some bandanas as well that we will pop around some patients' necks. Obviously, this depends on the temperament of the patient. So I would say for a care, hands-off patient, the bandanas probably aren't that practical, because then it's also spraying them. But we can put towels under their kennel door and things, or put it on the outside of their door, and that works quite well. So some of our patients may require a complete hands-off approach. So these are the patients that they won't tolerate any sort of handling. They are just happier when they're left alone, really. So these friends will most likely need to be IM sedated with the owner. So we'll be using a long line technique, which I'll talk about in my part 3. However, if a patient is worse with their owner, then we can do it away from their owner, but normally the patients feel safer with their owners around. So I would just say, obviously, as a nurse, I can't prescribe, but if I can see that there is a patient who is extremely anxious, and just from experience, I don't think that this patient is going to fall asleep that easily on the prescription that the vet's prescribed, then I would just ask the vet to, if they weren't there, to pop down, perhaps speak to our anaesthesia department and just see if there was something else that we can give, just so then we don't have to repeatedly IM a patient, because that's also going to bring up stress levels for the inpatient. So actually, if we can just have it done once, that's amazing, really, and it just makes everyone's day smooth, and most importantly, the patient's. So once they have been IM'd, the patient may stay with their owner, or we'll pop them in a kennel, just in a nice quiet area, basically, just so that patient can fall asleep in hopefully the most relaxed area that we can find. So once that patient is asleep, we would fit a harness and muzzle and buster collar. I would say that's our most important thing, because then once that's on, we've protected ourselves. We would then place an IV catheter. So it might be that we could do it there and then in the room that we're in, but then obviously if an owner has a blood phobia, for example, we may have to transport the patient or just ask the owner to leave while we place this IV catheter. One thing that we would always use a long line and attach it to the IV, and we leave it unwrapped. So we don't bandage the IV catheter in, and that's just for a visual inspection from afar. But we would always attach a long line to it. What we don't then want to do is attach that long line to leads, because what we have found is if we're walking a patient, they pull on a lead, that long line can then snap, and then you have no IV access, or you have to get very close to the patient in order to get IV access. So actually, this is why the harness is such a crucial bit of kit, is because you can pop the long line up, so you can kind of like roll it up and tie it to the harness. I do have some photos to show. And then we can always then put another long line on there and then have that coming out of the kennel. And then you could perhaps tape that to one part of the lead. But yeah, as a rule, we don't tape long lines to harnesses. No, we don't tape long lines to leads. So before we are going to reverse the sedation that we have given, if it is one that we can, we're just going to make sure that the patient isn't going to continue a CRI of a sedative. So for example, dexmedetomidine, if we have an extremely hands-off reactive patient, we will sometimes keep them on a continuous rate of dexmedetomidine just to help them feel a bit calmer, and then also it just allows us to be able to do what we need to do to the patient. And we obviously don't want to be reversing that patient, because then the medication won't work. So these are some photos of how we set up a kennel for our hands-off patients, or even just for our care, so a kennel garter. This is really helpful. So you can see we've got the drip pumps hung up on outside of the kennel, and this is basically, we don't then need to go into the kennel to press start, stop, or whatever we need to be doing to those infusions, and also changing the fluid bag, everything's on the outside. So we can also, that bottom pump is a syringe driver. So that's where if they were on dexmedetomidine, for example, we could then potentially bolus them an amount so they sleep if we did need to get them out, if they had urinated or defecated in their kennel, for example. We can also administer medications via the fluid line, which is helpful. And then we obviously have some clear signage on the doors. So one of them says care, and then it just says the reason why they're a care. So I think that's quite important, because one patient might be a care only for temperature, but then we would still have this sign up. But then another patient might be a care for everything, and they just don't like being touched, basically. So it's just really useful for us to know. And then also just how they react. So actually, are they going to lunge when we open the kennel door? So that's when we would need more of a hands-off approach. Or are they just a care if you are touching their painful area? So it's a really simple thing, but it works wonders for us. We also have some staff-only signs as well. And obviously, being a teaching hospital, we can have students, and we obviously don't want students accidentally opening a kennel door or something. So if we clearly label that it's staff only, then everyone knows that. You can see the lead is trailing out of the kennel as well. So even if this was a hands-off patient and we weren't walking them during their stay, actually, if we did need to, we still have that access, which is helpful. One thing that this photo doesn't show is a bowl of water. So obviously, if they're a hands-off patient and we're not able to offer them water, then they need to have that in their kennel. And then we can actually feed them. So we have had some very reactive patients before where even when we go to open the kennel door, that's made them feel very uncomfortable. So actually having like a really shallow tray that you can just then post under the door, and then they can eat, and then you can bring it out again. So that's it. They were photos of our hands-off kennels. So then the reason behind, so obviously if we have a cardiac patient and they can't really be on fluids, but if they're a hands-off, we kind of do need that access. So obviously this would be down to the vets, but the fluids, they don't even need to be running in at like a proper rate, so to speak. It could just be 1 ml per kilo per hour, just to keep that IV patent, which is really helpful. So we need to make sure that the patient is in a suitable size kennel. Like I said, we need to make sure that they have water in with them, and then we need to be posting food under, or perhaps we are able to open a kennel door and pop it in there. But we just don't want them to be too squished, basically. So make sure it's a suitable sized kennel. As I said earlier, we're going to make sure that unrealistic procedures are crossed off on the hospital sheet. And then on the day of discharge, we'll starve that patient just so we can remove that IV and do any other bits that we need to do before they go home. So I feel like this is really important, that on handovers, we don't want to be over or under exaggerating the temperament of this patient, because it can really affect the quality of care that patient's getting. Clear notes are really important. It's really, really helpful, especially people working different shifts, even down to how we got a clavaceptin tablet into a patient. It's just really helpful, as I'm sure everyone can agree. And then even tips on how to handle the patient. So say I was able to do the full patient check. We didn't push it with a temperature, but we could say that perhaps we did so this isn't a hands-off now, this is more of just our care ones that we're still able to do our checks to. But it could be that we decided to do it outside, and actually the patient was much more relaxed outside. So it's just little bits like that. Nice clear notes are really helpful. I would number one rule really is never put yourself at risk. So if you're not confident, if you're not happy handling an aggressive patient, then just ask for support from the team around you. And then, as I've already spoken about, just ensure that there is clear signage being used on your kennel doors. Just so everyone is aware of what's going on with that patient and their triggers and things. So some examples of the signs that we have here. So obviously we've got the care and the staff only, and then there's the space, like I said, where you can write their triggers. And then the temperament with the smiley faces. So a bit like a verbal handover, it's quite important that these aren't over or under exaggerated. So if we've got a patient that is they're very anxious, but actually they're not a bite risk, but they are very worried, then we would still put them as a smiley face, but then we would just write anxious, go slow. If they were a care or just a potential bite risk for procedures only, then we would do a smiley and middle face together, and then we could write in the box, care for procedures, muzzle, or if the patient wasn't happy being muzzled repeatedly, then we could then pop a buster collar on and just say, care, use buster collar for procedures, or do not remove buster collar. And then if a patient's really upset with us, then we would put them as the sad face. And that's just a nice visual for people to see. At the end of the patient's stay, or as soon as we know about a patient's behaviour, we add it not only on our laminates, but also on the patient's hard record, on their computer record. And this is just so when that patient comes back in, obviously being a surgery ward, we see our orthopaedic patients back for their post-ops. So if this patient does ever come back to us, we then know, okay, this patient was a care for procedures last time. These are his triggers. Let's avoid those this time. And it's just quite nice. So we have a bit of a heads up really to know how to handle that patient. So then I thought I'd just include a slide about our IV placements and how we place them basically. So we have them on a blue tray, and this is just really good because it's very manoeuvrable. So no matter where you are in the hospital, and then also if the patient wants to lie on the opposite end of the room where your table is with all of your equipment on, then we can do that because that's where the patient wants to be. So we can work around the patient. We don't want to be trying to really encourage and then potentially end up dragging a patient to an area just to have a procedure done when actually we can go to them. So yeah, we will not bandage them in, so we can see them from afar, and that's basically just so it's more hands off. The patients don't need to be touched basically twice a day to have a bandage change. To have that IV checked, we can just flush it from their long line. Hind limbs are great for placing IVs in, because we're away from their face. So even for a brachycephalic, this is quite nice. They're not being restrained around the neck, therefore their airway's a bit freer. But also then for a care/anxious patient, it's just, I just always find that they just react a bit better when it's a hind limb IV where possible. They do kink though, so they're not my favourite vessel, but actually if we're able to get that IV in and then that patient can have a nice smooth induction for whatever it is that they're going for, and then when that patient is asleep, they can then move it to a forelimb or a more suitable area, then that can be, that can easily be done as well. Thank you so much for watching. In the next video, I will be talking about our long line IM technique. So yeah, thank you.